recording. Right, good afternoon, everybody. It is a great pleasure to welcome all of you here this afternoon at our weekly deep dive. And today is a very special one because we're going to cover a topic that I think I certainly need some training on, one that is quite challenging often in practice as well. So I really look forward to this. My role today is going to be mainly that of housekeeper. So I will just introduce one of the chairs and then hand over to the team that is presenting today thereafter. So before we start, I just want to give a word of thanks to our team that puts these sessions together with the different departments around the country. Specifically, Estelle Verburg, who coordinates this, Elzaan Jansen van Rensburg, who works closely with Estelle to do this, Melanie Davids, who does a lot of the admin, and the Blood SA team for their support. And you'll hear a lot more about the role of Blood SA in the deep dive as time goes on. So the way we're going to do this is there will be an opportunity at the end for questions live to be asked, but you are very welcome and actually encouraged to put in any questions in the chat box as you think of them and go along, or perhaps your own experiences. I think it's very useful to hear from each other. If you do something slightly different, then we can discuss that. This session, as you can see, is being recorded and hosted on the University of Cape Town VULA website. If you need access to the recording, you can email Melanie Davids. We will put her email address in the chat box if you want to watch this again. All these sessions are CPD accredited. At around the top of the hour, there will be a link in the chat box that you can click on and fill in your details. Also, if you want to receive the invitation every week, you can put your email address there. Then the CPD goes straight through to the Health Professions Council of South Africa, so you don't need to worry about anything else. So the pleasure I have today is to introduce our Tygerberg Hospital University of Stellenbosch team, and under the leadership today of Dr. Z. Chapanduka. Prof. Z. Chapanduka is head of the Division of Hematopathology at Stellenbosch University and NHLS at Tygerberg Hospital. And Z's got an interesting background, quite a broad background as a matter of fact. He's got a diploma in medical laboratory technology where he specialized in hematology and blood transfusion. Immediately made me think of the father of hematology in South Africa, Prof. Peter Jacobs, who also started with a technology qualification. And then he completed his MBCHB thereafter in 1990 at the University of Zimbabwe, following which he did an FC Path in hematology in 1995 at UKZN, and then a transfusion medicine fellowship which was a Swiss Red Cross one in 1996, after which he worked as the Deputy Medical Director of the Natal Blood Transfusion Service. At that time, SANBES wasn't fully established and we still had many provincial transfusion services. Z, you can correct me if I'm wrong there. He's held many leadership positions. He's also got an MBA from Liverpool. He's published 12 papers in the last 21 months, and his current research focus includes COVID-19, iron metabolism, MPNs, and business administration, leadership, and management aspects of laboratory pathology. So Z, really wonderful to have you here. Thank you for you and your team for taking the effort to get to this afternoon's program together. I will let you introduce your co-chair, Erika. And while you do that, I am going to put up a little poll that I'd like everyone in the audience to answer. Very simple. How would you score your knowledge of inherited platelet disorders out of 10? 10 being you like Z, and 1 being you know nothing. So please, while Z introduces his co-chair and I hand over the meeting to you, Z, everybody can just quickly respond to the poll. Thank you and enjoy the afternoon.
Thanks, Vernon, and thanks everyone for attending. Mine is a pretty simple task. I need to just introduce Erica. Dr. Erica Murray now is a new consultant in our department since January. She's one of our own and has been with us since 2018, yes. Erica has got a broad range of interests, but what I can quickly say is that she's very research focused, which I appreciate. She's also very teaching focused. So she loves teaching registrars. And from what I know so far, they do appreciate teaching as well. But I think before I hand over to Erica, let me just boast a bit on her behalf and perhaps on our behalf over here at Tigerbird. Erica got the Coulter Medal this year, or for last year. And the fact of the matter is that we've had a Coulter Medal drought of more than 5-6 years standing. So I'm quite proud of that aspect. Today, the topic, like Vernon rightly said, is a rather nuanced and difficult topic. It's got a lot of oddities and small, syndromes and conditions and biochemical lesions, inherited abnormalities, and all of the rest of it. So without wasting time, let me hand over to Erica, please, to introduce our speakers, who are Keshanya and Helena. Thanks.
Thank you, Dr. Z, for that kind introduction. Yes, so as Dr. Z mentioned, we're going to speak about inherited platelet disorders today. And this is an important topic as it is mostly very under-recognized, especially in adult patients or misdiagnosed as ITP. So we hope that by showing you some cases and familiarizing with how different inherited platelet disorders might look, that you'll be able to apply this in your daily practice. So our two registrars who are going to present today are Helena and Keshanya, and they're both senior registrars within our division of methodological pathology. Okay, thank you, Helena. Over to you.
Thanks, Erica. Thanks, Dr. Z. So today our goal is to tackle an approach to inherited platelet disorders. And often when you read around this topic, it's a whole bunch of tables that become quite difficult to understand and quite difficult to absorb. So what we've tried to do today is try and make a bit more of a practical approach and quite case focused. So potentially what one would see in the clinic, but also what we would see in the laboratory as well. So I hope that after today, we can give a better or deeper understanding of this very interesting entity. So inherited platelet disorders are a heterogeneous group of rare diseases, and they are caused by molecular abnormalities in genes that are relevant to both platelet formation as well as function. Over 60 types have been identified with about 75 genes recognized, and the dawn of next generation sequencing has really deepened our understanding into this very rare type of disorder. Interestingly, in 1949, two French clinicians, Jean Bernard and Jean-Pierre Soulier, described the first inherited platelet disorder, which was Bernard-Soulier syndrome. So the clinical complications vary from almost negligible to life-threatening. And this is probably why their prevalence has such a wide range, from about 1 in 10 to the 4 to 1 in 10 to the 6 persons. And if you compare this to, for example, von Willebrand's disease, as well as thalassemia, it's much less commonly seen. So how common is it really? This was quite a nice review of mainly first world laboratories, and reviewed sort of what they see and what tests they use in the context of inherited platelet disorders. And majority were signaling defects that were seen, as you can see here. So what we are going to cover today is a brief overview of platelet physiology, clinical and history and phenotype, as well as an approach to diagnosis and an approach to management. I really like this image here. It's a bit overwhelming at first and a bit confusing. But when you look a bit deeper, it really highlights the complexity of the platelet, as well as sort of what's going on inside the platelet and the most pertinent receptors. So you can see, hopefully at the end of the session, you'll be able to understand a little bit more about what they're talking about and what's going on. So you can see they describe Glanzmann's here, and Hermansky-Pudlak syndrome, just to name a few, as well as your platelet type 1 Willebrand disease. So hopefully you'll understand this a little bit better. So let's just have a brief overview of hemostasis. I'm sure this is bread and butter to most in the audience. But anyway, when there is a break in the endothelium, you get exposure of the subendothelium, and you get tethering of your platelets. Now, under high shear stress, your platelets start rolling, and von Willebrand factor catches your platelets, and you get binding of your platelets. Subsequently, you get activation of your platelets with platelet signaling, and then you get a shape change as well as granule release. Now, these granules are quite important, and we will talk about them a little bit just now. The coagulation cascade is also initiated. And here you can see the granules. So we have two types of granules in the platelets. We have the dense granules as well as the alpha granules. The alpha granules are more abundant than the dense granules. And the dense granules are largely involved in platelet activation. And I want to just remind you about what the contents of the dense granules are, because this is going to be quite important just now. And ADP is a very important dense granule component. So after our platelets have bound, we get firm adhesion of the platelet, and then we get formation of the platelet plug through platelet aggregation. And now, sorry, just to show my key is that GP2B3A is a very, very important receptor here, and we will explain later. So let's just briefly understand this phenomenal platelet. So the platelet needs to get made in megakaryopoiesis. It needs to hold on and change its shape, in which the cytoskeleton as well as the granules are important. And then the platelet has a very important function in terms of it needs to aggregate and form a platelet plug, as well as it is important in the coagulation cascade. And in order to do this, we need granules, and we need platelet receptors, and we need platelet intraplatelet signaling. So if we look at platelet production, just a brief overview, and I really, really liked this image because it highlights what genes are important in platelet production, but also where the most pertinent defects are when we're talking about inherited platelet disorders. So the platelet count is this balance between both platelet biogenesis, senescence, as well as consumption. Now here you can see that GATA1 is very important in platelet commitment to megakaryopoiesis, as is RUNX1, which facilitates in the proliferation and differentiation of the hematopoietic stem cell with result, and importantly, megakaryopoiesis, and also suppresses erythroid gene expression. And so as the platelet matures, the megakaryocyte matures, it extends these proplatelets which are released into the blood. And this process is highly dependent on myosin, which we're going to discuss just now. And what most of us know is the importance of thrombopoietin and the importance of thrombopoietin in megakaryopoiesis. So when we have a problem in platelet production or a problem in the platelet cytoskeleton, we get problems mainly in platelet number as well as platelet size. If we have problems in the actual function of the platelet, then we have problems in platelet function with decreased size. And as a result, we have bleeding because these platelets are not working nicely and forming a platelet plug. If we have problems in our granules, we have problems in activation and coagulation. And if we have problems in receptors, we have problems with platelet adhesion, activation, and aggregation, and as a result, bleeding. This is just a brief table just to highlight sort of where we're looking at things and hopefully kind of put your mind in the right place about what we're talking about. So if we have abnormalities of megakaryocytic differentiation, largely we don't see megakaryocytes. So that is, for example, congenital amegakaryocytic thrombocytopenia. Then if we have abnormalities in the megakaryocyte maturation, we can see familial platelet disorders as well as Paris-Trousseau syndrome and gray platelet syndrome. If we're talking about abnormalities of proplatelet formation and platelet release, these are largely the Meyer-Heglen related diseases as well as Wiskott-Aldrich syndrome and Bernard-Cillier. But what you're going to see here is there's a little bit of overlap because we know that platelet adhesion, when we're talking about glycoprotein 1b, is important, and its mutation results in Bernard-Cillier syndrome. And here, just to highlight some of the diseases seen, which we're going to cover just now, when you have a problem in your granule formation, such as Hermansky-Pudlak syndrome, as well as Sheda-Higashi syndrome, as well as gray platelet syndrome. And then the one most of us in the audience probably know is Glanzmann's thrombocythemia, where there's problems in platelet aggregation. So I'm going to hand over to Kesh here, who's going to introduce 3 cases, and hopefully these are going to get the brain juices flowing and wake you up slightly, and then we're going to try and answer the cases as best we can.
Thank you, Helena. Good afternoon. Thank you to the Deep Dive team for this opportunity. So our first case is a 61-year-old female known with a background of type 2 diabetes, hypertension, and a high BMI. Her HIV status was unknown. She presented with dyspnea, fever, and confusion, and was admitted with COVID-19 pneumonia in February of 2021. So her FBC was largely unremarkable, aside from a thrombocytopenia, and her renal function was normal and CRP raised in keeping with her clinical picture. A peripheral blood film was then done, which revealed a true thrombocytopenia with hypogranular platelets with reactive changes. So we can see that her thrombocytopenia was persistent over many years and was worsened with her admission, with a zenith on her present admission. So all her follow-up films noted the same morphology, macrocytic hypogranular platelets, and our differential at this point was ITP, EDTA changes, MDS, MPN, or an inherited platelet disorder. So case 2 is a healthy young baby boy who had a brother that died in infancy, was seen at Tygerberg around 6 months with numerous infections, difficult to manage eczema, a failure to thrive, persistent diarrhea, low lymphocyte subsets and low immunoglobulin, and a microthrombocytopenia. And we were working this patient up. So this thrombocytopenia was persistently small microplatelets, and this is an example of his platelets and peripheral blood film. Our case 3 is a 5-year-old boy. He presented with a history of bleeding and family history of bleeding since May 2021, a white cell count of 5, hemoglobin of 11.8, platelets of 92, and they were macrocytic platelets that were persistent. Additionally, his granulocytes showed Dolly bodies, as in the peripheral blood films. So our differential at this point was severe infection, DIC, or an inherited platelet disorder. So our three cases to contemplate, and hopefully by the end of this talk, we'll have a better way of managing these patients or working out these patients, would be a macrothrombocytopenia, an older lady with bleeding history, a microthrombocytopenia in a young boy with eczema and recurrent infections, and a macrothrombocytopenia in a patient with bleeding history and Dolly bodies in a family cohort.
So we've briefly gone over platelet physiology, and now we're just going to discuss the typical clinical history, as well as some phenotypes that the patients present with. So history taking in inherited platelet disorders is the cornerstone of your diagnosis. So important is to take a really good bleeding history from both the patient as well as the family. And importantly, to ask about consanguinity. And consanguinity is probably actually more common than we realize in the South African setting. Now, these patients typically present with mucocutaneous bleeding, which makes sense if you think about the function of the platelet. And they tend to have these unexplained or extensive bruising. They tend to have severe epistaxis. So this is epistaxis where there's bleeding for more than 30 minutes, where it's causing anemia, where they're needing to actually be admitted for this epistaxis. Females tend to give a history of menorrhagia and potentially oral bleeds, as well as bleeding during childbirth or other invasive procedures, importantly, dental extraction. So it's also important to look if this patient has any syndromic features. However, often the phenotype is quite heterogeneous. And then look at the platelet count. Often the platelet count is moderately low to normal. Sorry. However, it can be markedly reduced. And then to look at the platelet size, as well as take further testing to look at the platelet function. And importantly here, to take a very good drug history to make sure the patient isn't on drugs that may interfere with platelet function. And often, as Kesh highlighted with our first case, is that these patients are diagnosed as an ITP. So we have the ISTH bleeding assessment score, and this has largely been developed in the context of von Willebrand disease. However, at the exclusion of von Willebrand disease, the sensitivity and specificity of the bleeding assessment score actually increases. So it's still a very relevant and very good tool to use. And although probably at the bedside it's a little bit too long to actually do properly, I think if you're taking a good bleeding history, you're probably covering most of the important topics. A big disadvantage is that for most of the questions asked is that you have to have had a hemostatic challenge. And often in men or young children, this isn't the case. So suggestive clues in the history would be if it's a severe platelet functional disorder, that they present early in life with quite significant bleeds, such as intracranial hemorrhage or subdural hemorrhage following delivery. They can also have excessive umbilical stump bleeding or bleeding after circumcision. And interestingly, they could even present with bruising after handling or when they're crawling. As well as gum bleeding, prolonged epistaxis, and in females, menorrhagia or bleeding during childbirth. And importantly, as I highlighted before, this is mucosal bleeding. It's not your typical deep muscular bleeds. And then your mild platelet disorders usually present later in life, and they might give this non-specific history of easy bruising. So what we wanted to do is try and make this as little bit practical as we could. So if you're faced with the pediatrician phoning you about a neonate who has severe bleeding and thrombocytopenia, you're immediately going to look at the platelets. And if they're large platelets, you might start thinking along the lines of Bernard-Soulier syndrome. If they're normal size platelets, you're going to ask about if there's any syndromic features. Expand on this a little bit more just now, but if they have hearing problems and skeletal abnormalities, you may be thinking about a megakaryocytic thrombocytopenia with radioulnar synostosis. If they have a normal phenotype, you may think about congenital amegakaryocytic thrombocytopenia or even Glanzmann's. And if they have skeletal abnormalities, you may think about TAR syndrome. If they have a mild or moderate bleeding with large platelets and syndromic features, you might think about DeGeorge syndrome or Jacobson syndrome, or a May-Hegland deficiency. And if they have normal sized platelets, you might think about an ANGAR-D26 deficiency, a familial platelet disorder with propensity for AML. If they have neurosensory deafness, so maybe the ENT is phoning you potentially, or the pediatrician, also once again go back to the platelet size. Do they have a macrothrombocytopenia, or do they have normal sized platelets? In terms of a macrothrombocytopenia, you're going to be thinking about the May-Hegland disorders, and it's important to look at the neutrophil morphology. And if they have normal sized platelets, then once again, you might be thinking about a megakaryocytic thrombocytopenia with radioulnar synostosis, as well as a MECOM deficiency. So these are important to differentiate from each other, and pretty much the molecular diagnosis is going to help you here. If the patient has a history of albinism, most of the time they tend to have a normal platelet count and morphology, and you're going to be thinking about Hermansky-Pudlak syndrome or largely Shedaki-Gashi syndrome. They could have Griscelli syndrome, but they probably in this context present with more of a bone marrow failure type picture. They could have other skeletal abnormalities, such as your TAR syndrome. And once again, it could be your HOXA11 or your RBM8A, which is the mutation in TAR syndrome, which I'll expand upon just now. And if they have a macrothrombocytopenia, they may have a mutation in filament A. So what is TAR syndrome? Well, basically, it's a severe thrombocytopenia with normal sized platelets that present at birth with bilateral radii and cardiac abnormalities. And interestingly, the platelet count can actually correct with age. And they basically have a microdeletion in the RBM8A gene. And this codes for nuclear and cytoplasmic proteins that are important in splicing. And the hematopoietic progenitors have a reduced response to thrombopoietin. And as I mentioned, it's important to distinguish them from other conditions such as amegakaryocytic thrombocytopenia, MECOM, as they both cause early phase defects of megakaryoresis. And so you need the molecular diagnosis. Paris-Trousseau syndrome is actually also interesting, and often it's spoken about in the context of Jacobson syndrome. So Jacobson syndrome has these syndromic features of cardiac abnormalities, dysmorphism, and intellectual disability. And Paris-Trousseau is actually the associated bleeding disorder. So they're not really one and the same. And basically the defect is in the FLR1 gene, and this plays an important role in normal platelet development. And interestingly, they can have a dual population of megakaryocytes with both normal and immature megakaryocytes on the bone marrow trephine. So now we've kind of gone over the clinical history and phenotype. So now we need to figure out how to investigate these patients. And I've alluded to some of the important investigations, but we're going to expand upon this. So first of all, you need to take a good history and do a good clinical exam. The bleeding time was in fashion at a stage, but now it's largely out of fashion. And then it's really, really important to exclude other causes for thrombocytopenia. For example, malaria, as well as hematinics, as well as your DRCs, etc. So you're going to start with your basic coagulation screen, and usually that is normal. However, in some instances, for example, in Bernard-Cillier, it may be abnormal. You're going to do a full blood count and differential, and importantly, you're going to include a peripheral blood film, and we're going to highlight why this is important just now. Once you've done all of that, you will go on to do platelet function tests, and then you might do additional investigations. So I really like this diagram because it highlights all that's in this little block, but it gives a little bit of a better picture or better image. So important to remember that not all analyzers are equal, and that the automated platelet count is much more accurate than manual methods. However, in some instances, for example, if they have a microthrombocytopenia in the Wiskott-Aldrich patients, you might need to revert to manual methods. But in general, always rely on the automated platelet count. So the hematological analyzers use different methods for counting the cells. And there's impedance counting, which is largely due to the electrical conductivity of the cells, as well as the optical method. So impedance counting can be inaccurate if the platelet count is below 150. And these tend to be used on the older machines. And they are prone to artifacts from, for example, red cell fragments, because these are counted as platelets due to their size. And abnormally sized platelets are often underestimated. The optical method, for example, the Siemens Advia, which we use at Tygerberg, has an improved ability to discriminate between platelets because we use largely light scatter detection. And so it's a little bit more accurate than your impedance counseling methods. If you really want to be super focused and look at your platelets, you can look at immunological labeling using CD61 and 41. And then Kesh alluded to the mean platelet volume. So basically, this is the platelet crit divided by the platelets times by 100. And important to note that it becomes unreliable after 8 hours, especially in EDTA, which you can see highlighted on this graph over here. So if you're looking at your platelet volume, it should be on a fresh platelet sample. Your normal platelet volume is between 7 and 11. And if you're seeing an increased MPV, you might be thinking of, you'll be thinking of a macrothrombocytopenia, but you might be thinking of conditions such as Bernard-Soulier or gray platelet syndrome. If it's extremely low, you might be thinking of Wiskott-Aldrich syndrome, but it's important to note that the MPV measurements can vary up to 25%. I'm not going to highlight this too extensively, but it's very important to exclude pseudothrombocytopenia. As you can see here, in your normal EDTA tube, you can have a pseudothrombocytopenia due to platelet clumping or platelet satellitism or neutrophil thrombophagocytosis. And when you do that in a citrate tube, your platelet count becomes normal. Just to highlight that this was a very interesting case that was seen by Dr. Null and her team, where the neutrophils were actually phagocytosing platelets. It was a fascinating case. I really like this diagram in terms of approaching the size of the platelets. So if you've got excessively small platelets, you're probably going to be thinking about Wiskott-Aldrich syndrome. It's important to look at the patient. Are they syndromic? And then you might be thinking about your germline predispositions to myeloid malignancies. And you're also going to look at your skeletal, if there's any skeletal defects. As I've mentioned, your HOXA-A11, MECOM, and RBM8A. And then if you have a macrothrombocytopenia, you're also going to see, is the patient syndromic or is the patient not syndromic? If they're not syndromic, you're going to be thinking about largely receptor ligands, such as your Bernard-Soulier or your Willebrand type, platelet type. And if they are syndromic, you're going to be thinking about your May-Heglin deficiencies largely, and potentially your gray platelet syndrome. Other morphological clues that you might see on the peripheral blood film are Dolly bodies, as well as marked anisopoikilocytosis, as well as stomatocytosis, and your giant azurophilic granules in Sheda-Higashi syndrome. And here, this is very nice in highlighting where sort of the severity of the thrombocytopenia, how severe the thrombocytopenia may be. So for example, if you have normal sized platelets, you might be thinking of a congenital amegakaryocytic thrombocytopenia, but they tend to have a severe thrombocytopenia, similarly for TAR syndrome and similarly for Wiskott-Aldrich syndrome. If you have normal sized platelets, you may be thinking of Atres syndrome or familial platelet disorder with a propensity to develop AML. and they may also have quite a severe thrombocytopenia. If you're seeing large platelets, they tend to have a normal-ish platelet count, but for example, glands with thrombocytopenia, but they might have quite a severe bleeding phenotype, and similarly for gray platelet syndrome, although typically the phenotype is more moderate bleeding. And then in Bernard ciliae, it also depends on the phenotype, but you could have sort of mild to moderate thrombocytopenia and quite significant bleeding, similarly for the May-Hegland disorders. So if we're looking at the bone marrow, if it's one of us, if you've decided that a bone marrow is necessary and you've seen low or absent megakaryocytes with an associated thrombocytopenia, you might be thinking of congenital amegakaryocytic thrombocytopenia. If there's clustering, you might be thinking of H1, and if there's an associated hematological malignancy, you're going to be thinking about, is there a germline mutation associated? And if there's dysplasia, they can have a GATA1, X-linked GATA1 mutation. And so if we talk about congenital amegakaryocytic thrombocytopenia, these patients tend to be born with a severe thrombocytopenia, and it's largely due to a mutation in the MPL gene, which we know is very, very important in terms of platelet, platelet megakaryopoiesis. And in the bone marrow, you see absence of mature megakaryocytes, as well as they have an increased risk for progression to aplastic anemia, as well as myelodysplastic syndrome. And the treatment of choice is a bone marrow transplant. However, you can have rare mutations in the actual thrombopoietin gene with loss of thrombopoietin production. And in this case, a transplant isn't going to be very beneficial to these patients. So it's quite important to go back to the molecular diagnosis and confirm what the patient actually has. So if we look at platelet function testing, I'm going to only highlight a few, but we have light transmission aggregometry, as well as flow cytometry, as well as other subsidiary investigations. And it's very important to consider the pre-analytical factors. So one needs to use cautious tourniquet use, avoid hemolysis, basically to avoid platelet activation. And you need to make sure that there's enough sample. So sometimes you might actually defer further investigation until the child is about 12 months old. And you need to make sure that the patient is not on any medication that could affect platelet function, as well as any foods. Before doing light transmission aggregometry. And then important in terms of transport, you really need to handle the sample with care. You really don't want the platelets to be activated at all. So they should be kept at room temperature, and they should be handled with care. And then in terms of the sample, you need to make sure that it's been adequately mixed, that there's no platelet clumping, and importantly, to look at the patient's history and make sure there's no lipemia or icterus. So we have the platelet function assay, which basically the principle is that it uses citrated whole blood. So this is whole blood that is aspirated at high shear rates. And then there are agonists that are used that trigger platelet adhesion, activation, and aggregation that produce a stable plug over an aperture. So here you can see the platelet plug that's been formed over this aperture. And it's basically the time that's required to close this aperture. And so it's quite useful in screening for platelet disorders, and it'll probably pick up quite a severe platelet disorder, but you can't use this to differentiate between an inherited platelet disorder and von Willebrand's disease. So often the PFA may be normal or it may be abnormal, but you're going to want to do light transmission aggregometry. So what is light transmission aggregometry? Well, basically it's using platelet-rich plasma. It's giving the platelets an agonist. The platelets undergo primary aggregation, then they secrete their granules, and then they undergo secondary aggregation. And we can see how this happens due to the amount of light that is transmitted through the little tube. So platelet-rich plasma doesn't transmit light very nicely, but platelet but when the platelets have been activated, it starts to transmit very likely. You can imagine these little clumps of platelets. So it's kind of almost the opposite of what you would think. So this is really the gold standard in diagnosing inherited platelet disorder, inherited platelet disorders. But the problem is that it can be difficult to interpret mild defects. It could be affected by platelet size as well as platelet number. So you do need a relatively high platelet count, which is a problem in some of these conditions. And then it's affected by pre-analytical as well as technical factors. This is just a really long list of factors that could affect the platelet function. But what I wanted to highlight here is the platelet count. So when the test is rejected based on platelet count, there is a reasoning behind this. And what you can see from these tables over here, one with a high platelet, very high platelet count, one with a perfect normal platelet count, and as you get lower, you can see that sort of the sensitivity of the curves become less easier or become more difficult to interpret. This is an example of a normal light transmission aggregometry, and I don't want to spend too much time here, but basically you can see that these platelets have aggregated nicely and that there's no response to low-dose ristocetin. So if we're thinking about alpha granules, remember I told you that alpha granules had ADP, so these patients might have a decreased aggregation to ADP, collagen, as well as arachidonic acid, and you'll consider gray platelet syndrome most commonly in this scenario. If there's decreased ATP release and normal ristocetin as well as others, you might think of a Shida-Higashi syndrome. However, it's often quite non-specific, so I wouldn't put my money on this one. If there's an abnormal arachidonic acid response, you might think of thromboxane synthase deficiencies as well as your RUNX1 mutations. Importantly, to exclude any drug history. And then if there's abnormal collagen response, it's usually not in isolation, but you might think about storage pool defects, such as your gray platelet syndrome. And then ristocetin, with response to ristocetin, which is the one we most commonly know, basically what ristocetin does is it binds to your GP1B and it induces platelet aggregation. So if you have an abnormal response to low-dose ristocetin, you're going to think about von Willebrand type 2B or platelet type von Willebrand disease. And there are certain studies, for example, mixing studies that one has to do to confirm this. However, I think this is a bit out of the scope of today. If you have a normal response to ristocetin, but no response to others, there's probably a defect in your GP2B3A receptor. And if there's no response to ristocetin, but a normal response to others, you're going to be thinking of Bernard-Cillier. Just to highlight that one does get whole blood LUMI aggregometry, and the advantage here is that it uses whole blood and that the platelet count can be a bit lower. So, but it's not largely widely used, and light transmission aggregometry is really the gold standard in this case. So just a little bit of a case. So this is a child with a history of bleeding who had normal size platelets. He had thrombocytopenia, and he was now presenting to us with AML, and he had low arachidonic acid response. And in this situation, you may be thinking of a RUNX1. However, you need to interpret it in the clinical context. And so myeloid neoplasms with germline predisposition and platelet abnormalities are, for example, your RUNX1, your ANKRD26, as well as your ETV6. Your RUNX1 is largely a failure of your megakaryocytic differentiation, and these patients have a predisposition to acute myeloid leukemia as well as myelodysplastic syndrome. Your ANKRD26 is a mutation in the 5' untranslational region, and there's impaired proplatelet formation by the megakaryocytes. And here you tend to have increase in megakaryocytes with hypolobated nuclei. And they may show deficiency in your GP1B alpha as well as your alpha granule deficiency. And then in terms of ETV6, this is quite important in your actual platelet in your megakaryopoiesis, and you might have reduced expression of your platelet-associated genes, and you can see small hyposegmented megakaryocytes, as well as potentially mild dyserythropoiesis. So what we wanted to highlight conditions may be classified in two different classification syndromes. So this is the WHO, which we all know and love, and then this is the International Union of Immunological Societies classification for inborn errors of immunity. And you can see here that Sheda-Higashi syndrome, as well as Hermansky-Pudlak syndrome, as well as Wiskott-Aldrich syndrome fall under this classification. So this is the case of a 15-month-old male who had recurrent episodes of epistaxis and significant bleeding following circumcision, and it was also noted that he had oculocutaneous albinism with normal platelet count and morphology. And here you can see he kind of has a little bit of a non-specific response, but he has no second wave in ADP, and he has a poor response to epinephrine. Ideally, you would confirm this with electron microscopy, but to highlight that one should be thinking about Hermansky-Pudlak syndrome and Sheda-Higashi syndrome, which are largely problems in your dense granule release. So Hermansky-Pudlak syndrome is an autosomal recessive disorder, and there are a few different types, but HPS2 is largely associated with neutropenia. They typically have oculocutaneous albinism and lack pigment in their hair, skin, and eyes, with a mild bleeding diathesis, and they lack dense granules on electron microscopy. Sheda-Higashi, similarly, is also autosomal recessive, and it's due to a mutation of the LIST gene that encodes lysosomal trafficking. And they also have neurological abnormalities, as well as oculocutaneous albinism, as well as a dense platelet granule deficiency. And they also have neutrophilia, but they tend to have neutropenia, life-threatening infections with also a bleeding phenotype. And here your morphology is really, really going to help you, because you're going to see these neutrophils with large granules. Another case is of a 12-month-old boy who had a history of bleeding after circumcision, as well as his dental eruptions. He had a normal platelet count and size and morphology. And here it's quite strikingly obvious. If we look at the normal control, you can see that he pretty much only has a response to ristocetin here. So he has a Glanzmann thrombocythemia. And you can see here that he has a defect in your GP2B3A receptor, which is important in platelet aggregation. And why he has a normal response to ristocetin is because the GP1B receptor is working perfectly normal. So I remember Glanzmann's with the two N's, and that's why it's GP2B. However, I'm sure there's much better ways, intelligent ways of remembering this. But basically, it's an autosomal recessive condition that tends to present at birth basal type bleeding, and there are different types, so it depends on the expression of your GP2B3A. Type 1 with almost no expression, and type 2 with sort of mild expression. And they tend to have a prolonged bleeding time with a normal PT and PTT, and the light transmission aggregometry, as I showed, has a normal response to ristocetin. Importantly, it's to think about a differential diagnosis for these two patients, in that they could have a leukocyte adhesion deficiency. This is an autosomal recessive disorder that also is that's due to the failure of inside-out integrin activation, and so they actually can present like a GP2B3A on flow cytometry. But hopefully, you're going to distinguish this clinically as well, but flow cytometry is also quite useful in this scenario. And then you could get a RAS GRP2 defect, and basically it's due to a defect in platelet signaling, and so they can also have an impaired GP2B3A activation. This is another case where also had a significant bleeding history and he had more bleeding than his older sister. His parents are first cousins. He had a mild thrombocytopenia with giant platelets. And here you can see there's also quite a striking difference between the control as well as the patient, where the patient had a normal response to the other agonist, but no response to ristocetin. So this patient has a defect in your GP1B, and this is a Bernard-Cillier. So this is very extremely rare, but because it was one of the first cases defined, we know about it and hear about it quite often. And basically it has abnormal expression of your GP1B receptor, and they can have both a qualitative as well as a quantitative abnormality. And they typically present early in life with mucosal bleeding, and especially epistaxis and cutaneous bleeding and hemorrhage post-trauma. And the bleeding is typically disproportionate to the thrombocytopenia. And here highlighted, as we've highlighted, light transmission aggregometry is really going to cinch the diagnosis for you here. And the treatment is largely preventative. So flow cytometry can be very, very useful, particularly in your Glanzmann's and your Bernard-Cillier. And the big advantage is that you can use a small volume of blood and it's not influenced by the platelet count. So typically what we would look for on flow cytometry is your expression of your GP2B3A in Glanzmann's thrombocythemia and your CD42B and 42A in Bernard-Cillier syndrome. These others are quite rarely used and described, and so you might not see it as commonly. And so just to give an overview and of the advantages and limitations, we've highlighted most of them, but the big advantage of the peripheral blood film is it's going to tell you how the platelets look, and it's very easy to do. The PFA is very rapid and simple. However, it's not going to identify mild disorders, and it's not going to exclude von Willebrand's disease. Platelet aggregometry is really the gold standard, but it's very, very labor intensive, and you need quite a large blood volume. Flow cytometry is very, very useful in looking at expression of glycoproteins. So now we're going to go on to electron microscopy, and Kesh is going to give us answers to our cases.
So electron microscopy is a microscope that uses a beam of accelerated electrons as a source of illumination to analyze ultrastructure of tissues. So if we imagine a platelet's ultrastructure as a cookie biscuit, a normal cookie biscuit would have chips, chocolate chips and Smarties. So dense granules being the Smarties and the alpha granules being the chocolate chips. So normal platelets would have both. When there are no dense granules, no Smarties, as Helena said, there would be a variety of conditions. When there are no alpha granules, there's no chocolate chips, there would be conditions like gray platelet syndrome. And when both are absent, there will be conditions like Wiskott-Aldrich syndrome. So our first case, just to remind you, was a 61-year-old female with persistent mild to moderate thrombocytopenia, a history of bleeding, easy bleeding, and a family history of bleeding. So the most likely diagnosis, once these others have been excluded based on morphology and further testing, was gray platelet syndrome. So the clues here would be an older, mild bleeding, macrothrombocytopenia, and these gray platelets. So this patient actually ended up being known with gray platelet syndrome after further discussions with her clinicians. She was initially misdiagnosed as an ITP. On prior bone marrow biopsies, the first one showed a normal cellular marrow with a peripheral cause with a thrombocytopenia and a neutropenia. And the second bone marrow showed a mild to moderate fibrosis. Unfortunately, there was no record of electron microscopy to confirm this diagnosis, and she was known with an elevated vitamin B12 level. So she had an interesting family history. So she was in a consanguineous marriage. So to her husband, they were second cousins, and she had a daughter with a bleeding disorder. Her mother was known with AML, and her sister and her nieces were both known with bleeding disorders. So according to her family, she was diagnosed with gray platelet syndrome in the 1980s. So the outcome of this patient, she required intubation and ICU admission for her COVID-19 pneumonia, complicated by other infections. She did show improvement, was extubated, but required re-intubation and ultimately demised after 39 days in hospital due to her COVID-19 pneumonia. So gray platelet syndrome, it's a defect in platelet granules. It's a rare autosomal recessive disorder with mild to moderate bleeding and characterized by impaired alpha granule biogenesis. So this was first described in 1972, and it's quite a rare condition. There are about 60 to 70 cases worldwide, and it's mapped to chromosome 3. So it's an NBL2 mutation, a scaffolding protein that's involved in alpha granule formation. And this NBL2 mutation belongs to a family of beach domain containing proteins. So these domains are highly conserved because they're regions crucial for protein-to-protein interactions, membrane dynamics, vesicle trafficking, lysosome size regulation, and synaptosome formation. So they're not expressed not only in megakaryocytes, but other hematopoietic cells. So this is more than just a platelet disorder. So these NBL2 variants can include, can result as a result of multiple mutations. So just to highlight, more than just a platelet disorder, the main features are progressive macrothrombocytopenia with a median platelet count of 57, a bleeding tendency that can be mild to severe, and a platelet count that is inversely related to age. So on the peripheral blood film, you'll see large and giant platelets that look gray in color, and variable other cytopenias, low leukocyte counts, decreased neutrophil granulation, and impaired neutrophil traps. So this results in a deranged innate immunity and associated susceptibility to infection. Also associated with bone marrow fibrosis, and this can be progressive as was seen in our patient. So this is due to a release of PDGF and profibrotic substances and splenomegaly that is independent of the fibrosis. So they're also known with extensive peripoiesis of neutrophils, and this is due to mislocalization of P-selectin on megakaryocytes when they interact with neutrophils which express PSGL, and this promotes this peripoiesis. And they're also known by an unknown mechanism, as seen in our patient with an elevated vitamin B12. Gray platelet syndrome also has a host of autoimmune manifestations, and it's something to think about when you see a patient with autoimmune disease. So electron microscopy remains the gold standard for diagnosis, and we ultimately decided that we would do electron microscopy on this patient because we could not find her prior records, and she did have reduction in her alpha granules. So there were no chocolate chips. Our next patient, just to remind you, was an infant child with thrombocytopenia. He had a triad of autoimmune conditions, eczema, and microthrombocytopenia. On his electron microscopy, alpha and dense granules were deficient, and he was actually thought to be a Wiskott-Aldrich syndrome, but the answer lied in his genome, and Sanger sequencing confirmed a novel hemizygous variant in exon 4 of Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome is a platelet cytoskeletal defect. It affects about 1 to 10 per 1 million males, and the X-linked version is a milder phenotype. So it's a molecular defect. It's an X-linked recessive disorder in the WAS gene, encoding the WAS protein. So the WAS protein is a key regulator of actin polymerization, and signal transduction and cytoskeletal rearrangements. This results in premature proplatelet formation and shedding, and there's also a peripheral component to the thrombocytopenia resulting in autoantibodies. So the clinical triad, as seen in our patient, was autoimmunity, eczema, and thrombocytopenia. They also have an increased risk for developing lymphoma and autoimmunity. So on his lab investigations, you'd have a low MPV, thrombocytopenia, decreased T lymphocytes, low immunoglobulin levels, and vaccine responses. Electron microscopy which showed decreased dense and alpha granules and mitochondria. So just to compare the X-linked and the classical WAS, they're very similar, just the S-linked would be a milder version, a milder phenotype. So case 3 was the 5-year-old boy with macrothrombocytopenia and Dolly bodies. And this is an example of his platelet aggregation, which showed very non-specific findings. And we needed further molecular testing. But just to highlight that there's normal ristocetin-induced platelet aggregation, which excludes Bernard-Solier syndrome. So MYH9-related macrothrombocytopenia is a platelet cytoskeletal defect, which is autosomal dominant and results in a macrothrombocytopenia and these dolly-like granulocyte inclusions. So as the megakaryocytes lack contractile force, there's reduced migration to the vascular sinus with altered proplatelet formation, resulting in these decreased platelet release into the marrow. So there's a host of MYH9-related disorders, but the clinical features stand out, which is bleeding, sensorineural deafness, cataracts, and nephritis. On laboratory investigations, the platelet count would be between 20 to 130 with these large platelets and dolly-like inclusions, which differentiated from Bernard-Solier. But the definitive diagnosis, as mentioned, is heterozygous mutations within the 41X MYH9. So just to highlight the importance of a peripheral blood film.
Cool. So as Kesha alluded to, the molecular diagnosis is quite important in most of these cases. And we've kind of moved away from looking at a targeted specific phenotype, rather gene, and we've moved towards rather using an NGS either gene panel or whole exome or whole genome sequencing. But important when you're looking at the gene, you really need to consult genetic counseling because they may need to do carrier testing as well. There's also issues around risk for malignancy and what do we do with this result when we found it. So there are actually NGS focused panels that are available to us, and in some patients at Tygerberg, we've actually used the Invitae panel, and you can go across to this website here, and they offer these sort of really nice grouped panels for certain conditions. And this is their platelet panel. And you can see here that they offered a myriad of genes, and we've highlighted most of them. And in Kesha's case, we used the Invitae panel to look for the MYH9 gene, which we ended up finding was positive. This is a very nice overview of all of that we've been discussing, and it kind of helps you to focus where you should be going down the algorithm. So is there thrombocytopenia present, or is there not thrombocytopenia? What is the size of the platelets, and what does the platelet aggregometry look like? And so hopefully this gives you a really nice overview. Importantly, if your patient has completely normal looking light transmission aggregometry, but still a bleeding phenotype, you may think about Scott's syndrome. And this is quite an interesting syndrome. It's autosomal recessive, and it's a missense mutation in your ABCA1 lipid transporter. And basically, this means that there's reduced phosphatidylserine translocation. Now we know that phosphatidylserine is very, very important for coagulation and providing on the platelet, and it's extremely rare, and the clinical presentation is that they typically bleed after invasive procedures, and women might present with postpartum bleeding, and the diagnosis is largely as well as a prothrombin complex index. And your treatment is largely supportive, platelet transfusions with tranexamic acid for mucosal bleeds, and you may even consider recombinant factor 7A as a second-line therapy. So that takes us on to management, and we're nearly at the end of our presentation. So basically, important for these patients are preventative actions. So you need to provide the patient with a card or something that highlights what their diagnosis was, And in Kesha's case of the gray platelet syndrome, this probably would have been quite useful if we'd known her diagnosis from the get-go. Also to establish a list of medications that they should avoid, for example, NSAIDs. You wouldn't want to be giving your patient with a bleeding risk NSAIDs. And then it may be quite difficult, but they might need to have lifestyle changes in that you don't want these patients to be doing big contact sports because the risk for bleeding is quite significant. Importantly is regular dental care. You don't want these patients to have terrible teeth and they're needing dental extractions, which just perpetuates the risk for bleeding. And then they may need to actually have iron supplementation if they've got this ongoing bleeding. So it's kind of your approach to a normal bleeding patient, but if there's mild or moderate bleeding, you're going to use local compression. You might consider antifibrinolytics such as tranexamic acid. Now, tranexamic acid blocks lysine binding sites and therefore facilitates in stabilizing clot formation and is very, very useful in this context. You might also consider desmopressin. Now, desmopressin results in the release of both factor VIII and von Willebrand factor from the Weibel-Palade bodies. Importantly, in these patients, they can have a risk for hyponatremia, and you should give them a testing dose. And then in really severe bleeds, you might want to give activated recombinant factor VIIa, which basically just bypasses the coagulation cascade and activates the common pathway. This is quite useful in patients who have quite significant bleeds where you really want to avoid platelet transfusions. Thrombopoietin receptor agonists have become quite popular of late, although they might be of little availability to us in the South African setting. And then platelet transfusions are going to be one of your mainstays. However, you really need to restrict this to severe bleeds. You need to give leukodepleted single donor platelets and ideally HLA matched platelets, especially in platelets with Glanzmann's thrombasthenia and Bernard-Soulier syndrome, as well as Wiskott-Aldrich, because they have this increased risk for alloimmunization. In terms of surgery, you're going to apply sort of the same principles to minor that you would apply to a mild or moderate bleed with tranexamic acid as well as desmopressin, and you're going to try and keep the platelets above 30 for dental extractions, and for minor surgery, the platelets above 50. If we're going on to major surgery, you may want to consider desmopressin, and especially for Glanzmann's and Bernard-Soulier, you may want to give platelet cover. But obviously, you really need to be quite cautious in giving platelets to these patients, and ask your surgeons if they can practice hemostatic measures for the patient. And ideally, you're going to have your platelets above 80, and if they're having ophthalmology or neurological surgery, they need to have platelets above 100. In terms of pregnancy, generally these patients don't need much management during their actual pregnancy. However, it would be ideal to know if the baby is a carrier. Your C-section should be managed as surgery, and your vaginal delivery, you may need to use tranexamic acid or recombinant factor VIIa. And then spinal epidural anesthesia is generally contraindicated in your more severe forms, such as Bernard-Soulier and Glanzmann's thrombasthenia. And then importantly, to try and avoid any invasive procedures and assisted deliveries, because the newborn may have risk for bleeding as well. So we've moved quite far in terms of giving these patients definitive management. And I've highlighted that in some cases, they may benefit from a bone marrow transplant. For example, those with a germline predisposition to myeloid malignancies, your Glanzmann thrombocythemia, your May-Hegland deficiency. And in Glanzmann's thrombocythemia, we are nearly or Gene therapy is on the horizon, and similarly for your Wiskott-Aldrich syndrome patients. So I hope that we've given a better and a deeper understanding of this diagram over here and some of the defects that you may see in inherited platelet disorder. But it's important to think about it in your patients who have this mucosal type bleeding history. They may or may not have a history of thrombocytopenia. And then importantly, to look at the size of your platelet, and that's going to guide and focus your investigations. So thank you very much for your time. And we'd love to take any of your questions, and hopefully we can answer them.
Thank you, Helena and Kesh. We really appreciate that you did such a good job at simplifying a very complicated group of disorders. I see that there are some questions in the chat. Maybe we can just go through them. It's not going big. There we go. Okay. I'm not sure where it is. One of the questions was about if we have what are the red flags to look out for in a patient with ITP for an inherited platelet defect?
Okay. So it's important to look at the size of the platelets, but as we know in ITP, they can have larger platelets. And then it's also going to be maybe a family history that's important. And you might want to, if you're really suspecting a inherited disorder, you're going to take this patient on to light transmission aggregometry. But really, I think the patient's clinical history, so they're going to have a bleeding history, as well as any associated morphology is going to be quite key. But I think, as we know, ITP, particularly in the pediatric setting, is a diagnosis of exclusion. And so the patient should really be worked up quite extensively before you make the diagnosis of ITP.
Yeah, so I think I'm just going to add one thing on it. And ITP is often treated with steroids, and then if the patient is refractory if the platelet count is refractory to steroid treatment, I think then you should really be starting to think about excluding an inherited platelet disorder. One of the things that are commonly done for our patients in steroid refractory ITP is that we do bone marrows looking for infiltrates and NDS. But another thing that we do is we also at that point assess the morphology quite rigorously for the platelet morphology as well as the associated leukocyte morphology. But then also from the clinician side, just to highlight at that point, maybe you should be reassessing the patient and the family history for features of inherited platelet disorders, and considering that some of these platelet disorders are linked to predisposition to malignancy or PID. So also assessing for infection risk. And then there might just have been something that was overlooked, like the patient is actually deaf and you never really thought about it, but now you have deafness and a low platelet count together. So those kinds of things would point towards inherited platelet disorders. Can we just find another question? Which center is doing electron microscopy? Well, do you want to talk?
Yes, so we are actually doing electron microscopy with the help of our colleagues in anatomical pathology. And we have a Professor Pretorius from human physiology at main campus that is an expert in electron microscopy for red cells and platelets. So she assisted us with our morphology for the electron microscopy.
I don't know if there's anybody else across the country that has an electron microscopist or that is able to interpret these. Just let us know in the chat for our colleagues.
I think there were some more questions higher up, Erica, in the chat towards the top.
Yes, thank you. So I see there's also a question about the difference between a PFA 100 and PFA 200.
Michael already answered the question in the chat box, but basically there's just an additional cartridge that looks at ADP as well as calcium, and it evaluates ADP receptor agonists like clopidogrel.
Yeah, so at Tygerberg, we don't have a PFA 100. We have the light transmission aggregometry. So that's kind of our focus here at our center. But just to highlight that the PFA 100 and 200 systems, they're both there to assess primary hemostasis. So either von Willebrand's disease or platelet function disorders can cause a prolongation of your PFA 100 or 200. And in the 100, there's two cartridges, the one assessing epinephrine and the other one assessing ADP. But what they found is that even though there is an ADP cartridge, it isn't very good at picking up defects to clopidogrel. And so they made this new cartridge, which you can use on the PFA 200, which assesses the P2Y12 receptor more accurately and is better for use for monitoring clopidogrel. Are there any other questions that you can see there, Vernon? Sorry.
I think there was a question about pseudothrombocytopenia, which was answered in the chat, but perhaps just for those who didn't see it. Right?
Sure.
Sure.
No, I'll speak, that's fine. There was a question about pseudothrombocytopenia and what we can do in those cases. Should we be doing platelet counts on titrated tubes? I think the emphasis there should be just that when you see a low platelet count, always think about pseudothrombocytopenia. And if a reflex peripheral blood smear hasn't been done, then request it to make sure that there isn't a pseudothrombocytopenia. And then if the patient requires a platelet count, maybe they're going for surgery or you're concerned the patient is bleeding, then to use a different anticoagulant. So we are very familiar with citrated tubes in our department, obviously. So we just request that they do it on the citrate tube, and we hope that there isn't platelet clumping on citrate, because mostly pseudothrombocytopenia is EDTA mediated. But it doesn't, not to say, thank you for your comment there, Prof. Lowe, that you won't have clumping on the citrate, and then you just have to move on to a different anticoagulant, for example, a heparin tube, until you find a suitable anticoagulant that doesn't induce clumping of the patient's platelets. Right, I think I have attended to all of the questions now. Kesh is responding to something.
I just asked there towards the end if anyone has access to molecular testing panels.
So we've worked quite closely with the clinical genetics team, and they have actually been able to offer the Invitae panel for a lot of our patients, which is really, really wonderful. The advantage with Invitae is that they have these focused gene panels. You can go onto their website and have a look. And their turnaround time for an NGS panel about 2 weeks. The great advantage as well is that they also offer free carrier testing. So for example, they will test the mother and they will test the sisters or whatever the case may be. And it's relatively cheap. It's about $500, which is a lot, but if we're thinking about next generation sequencing, it's quite good. So we've been able to do it at Tygerberg through our genetics team. And so I wonder if GSH's genetics team may be able to offer it as well. I'm not sure, but I do know it was quite a story to get Tygerberg Hospital's approval for the Invitae panel.
That's very helpful. Thank you so much. I'm going to...
We've got another question.
Yes, go for it.
From Garrett. He or she, Garrick sounds like a man. Sorry, I apologize. Is there a utility of thromboelastography in IPD? I suppose it's largely been surpassed by LTA genome studies. So
there may be utility, absolutely. It's just not one of those tests that we really have in the lab. It's more of it's seen in an ICU setting. So if it happens to be that it's suggestive of a low platelet function, then I suppose you would go on to doing more formative testing like the LTA. And thank you, Vernon, for making videos on pseudothrombocytopenia.
I think everyone has appreciated them.
Perfect.
Okay, I've thrown in the link for those who are interested. And then I'd like to quickly relaunch the poll that I presented in the beginning. And I would really like to hear and think, compared to your initial answer, where you are now after the presentation. So it'd be great. I hope everyone, can you see the poll? Yeah, I see people are answering. So let's quickly hear. Okay, that's fantastic. I see there is huge improvement, which just means that the Tygerberg team has been extremely efficient. You can't see it yet. I'll share it in a second. Let's give a few more seconds. This is very interesting. Okay, there we go. Let's share the results. Just tell me if you can see it.
Yes, we can.
Okay, great. So there you go. So I think we had no 9s or 10s. We had lots of 1, 2, 3s and 4s. And I think from between 5 and 8, it was about 14, 15% each. So Tygerberg, you've done a fantastic job. Knowledge has increased, which means patients will be cared for better. And I think all of us have been enriched. I already see marks going up in the exams. So thank you so much for that. Right, can I hear any closing remarks from our chair people before I just close with my final housekeeping comments?
Just a thank you to you and your team. Thank you so much for letting us speak on this platform.
It is a huge pleasure and it was wonderful. Z, any final words from you?
No, nothing from me, Vernon. Thank you very much to the deep dive team. Thank you, Erica, Kesh, Helena, and for the questions. I think we had a good number of questions, and thanks for answering them. Nothing more from me, Vernon. Thank you.
Great, thank you. Well, with that, I would like just to remind everyone to quickly look at the chat box. There is a link for the CPD registration. Please click on that, put in your details, and we'll do the rest automatically to the HPCSA. Again, a big thank you to Estelle Verburg, Elzaan, Janse van Rensburg, Melanie Davids, and Blood SA for all their work on putting this together. A huge thank you to Tygerberg. I think the comments in the chat, the thank yous, the words of appreciation from so many, and the very clear, beautiful presentations with wonderful analogies just speaks to the quality of what we've seen today. And you've really put the bar high for all of us. And yeah, so exciting times. Thank you. And we look forward to seeing everyone back next week, when we will have a session by a team from Natal on patient blood management. So we look forward to that. And I wish you all a wonderful evening until the next time. Bye-bye.